Hello. I'm
Hello.
so sorry. I was running a little bit late. It's because I was teaching my adult and geriatric class right before you guys. So, and that was a good class. No pressure, guys. Um, how's everybody this morning?
Super great. Thank you for
Wonderful.
being here to teach us.
Oh yeah. Well, I apologize for having to do it on a Saturday. I just wanted to try to get some time to catch us up. Because gosh, it's like Christmas happens and then like the whole world just kind of falls apart there for a while. The wheels come off. And then I was sick. Good grief. I've gotten sick way more often now so I've had COVID like 4 times, I think. Um,
So I have a question. Did you get the vax? Because more
did.
people got it that I know personally have gotten super duper sick. I never got it. Nobody in my family has gotten sick.
I'm
Just
thankful
throwing some
for that for
stats out
you.
there.
Yeah.
Just throwing some statistics.
Yeah, I had all the vaccines and everything, and that's the thing is that, but I see like inpatient patients at the hospital, and so and little kids.
Yeah, you're not allowed in the hospital without the vaccine. I know that.
Well, and I've got so I see the adults there in the hospital, and then I'll see little kids in my practice, and little kids bring it all in. I mean, like there's like I've got stock in Lysol at this point. And you guys give me 1 second real quick. My kiddo's knocking on my door just real quick. Hang on 1 second. Sorry.
Hi, Jody. I think we've had class together before.
Yes, we have.
Yeah.
I think it was with Dr. Johnson. Is that right?
Yeah. Pamela?
Yes.
Yeah. I think so too.
How
Sarah,
are you?
I'm great. Sarah, you look a little bit familiar too, or your name does.
I think I've been in a class with Sarah too.
Yeah.
I have 3 classes left, and then I will start pre-prac. So I'm excited.
Oh my
I don't know,
gosh.
like, am I a senior? What would that be equivalent to?
It means you're almost done.
Yeah.
Yay. We're having a party on the side, Doctor.
I heard that. Yeah, congratulations on being so close to being done.
Yeah.
Yeah, that's it's exciting and scary at the same time, I bet.
Yeah, it is.
Yeah, it was for me. I remember starting grad school and being like, I'm gonna be a psychologist and so excited. And then it's like I slept a few days and then all of a sudden they're asking me to talk about, what kind of gown I want to get for graduation. And I was thinking, is this it? Like they're gonna let me go. And yeah, there's an anxiety that kind of kicks in. You're like, I got to learn more. I need to learn. I'm not ready yet. Yeah.
Yeah,
But
that's what I'm feeling about that textbook, because I'm like, whoa, what? Oh my gosh.
you talking about the DSM?
Yeah.
Oh, yeah. Even the psychiatrists who wrote that feel that way about that book. They just,
Thank God.
I am, and we'll get going on our topics here because we do have a lot to cover. But real quick, what you need to know about the DSM is that it is a diagnostic system that is primarily categorical in nature, or it implies discreteness between all these things like ADHD and depression and bipolar and schizophrenia and so forth, as if those things are just by themselves, like a broken leg or a broken arm. Those are 2 different things. Now, that's not how the brain works. But the DSM is written that way for legal reasons, because law is needs black and white. It needs cutoffs. It needs categories. Whether we're talking about like criminal law or civil law. When I say civil law, think about like Social Security disability. I can promise you the federal government has an interest in how the DSM-5 qualifies somebody for a diagnosis, because disability hinges on whether or not you have it or not.
Right.
And somebody's got a lot of loud noises in the background there. I'm gonna. Is that Karina?
I
Is that
apologize.
your... Oh, no worries, no worries. It's you. Like I thought that I assumed it was me for a minute because I've got an 8 and a 5-year-old and 2 dogs. So.
I apologize. I just came back with one of the puppies from class, and I sat all 3 of them here with no height so that they stay put when I'm in class. So I got 3 dogs chewing up over here. I apologize.
We've got like a I guess a 20-week-old, 3-month-old. I don't know whatever that is.
Oh my
4-month-old.
goodness. Are you sleeping at all?
Not a baby. I'm talking about a puppy. So we've got a puppy he's older than that. He's like 6 months old. Yeah. And we've got Lucy is his older sister, the mini border doodle. She's 5, and his name's Leroy. He looks like a little mini bear. He's just a little mutt dog. He's just a handful right now, so I can relate. Anyway, so DSM-5, well, I want you to do 2 things. I want you to, 1, you need to know that medicine and the law considers it to be the Bible of what we do. It's the gold standard. If you ask anybody individually within either of those systems what their real thoughts about it are, they'll tell you that it's not super clinically useful. Based on what we know from a neuroscience standpoint now. Okay. All right. So
Thanks for explaining that. That helps a lot. And as I was reading through there, I saw some sections that would say comorbidity, meaning it's related to other things that you could find with somebody who's maybe diagnosed with this symptom. There's going to be relations to possibly some other areas over here. That's why you're saying the brain doesn't work like that. It's not just in one category.
Right.
Okay.
And that's where another word for comorbidity is co-occurring.
Okay, good. Thank you.
I don't know why we don't just use that word, because like I remember hearing that word in grad school. I was like, people are dying from this stuff. Like, but that's not what it means. It's just co-occurring. Yeah. So I'm gonna get some PowerPoint slides pulled up real quick. I'm trying to remember. I mean, there's no way I wouldn't expect you guys to remember where we left off last time, but what I want to do is I want to highlight. I'm going to jump back in ADHD, autism, and then start talking about DMDD and depression today. Okay. And then from there, we'll talk about tomorrow night's class. We'll go into probably finish up with depression and bipolar, talk a little bit about psychotic disorders. And I think that catches us up for the most part, right? Because we're in officially week 4. Yeah.
Yeah, we're officially, today's the 14th. Yeah, we're at the end of week 4.
Yep. Okay. Perfect. So, let me do this. Let's start with the advanced assessment of ADHD PowerPoint slides in case you guys want to look on your side. I will share that too on my screen, and then also week 2 PowerPoint slides, the neurodevelopmental disorders, those 2 slides. All right. And I'm going to share my screen there. Okay. So, one thing I want to highlight that's really important as it relates to diagnosing neurodevelopmental disorders in general, and this applies to ADHD, but also autism, and I would even say it applies to intellectual disorders for the most part. When a diagnosis is made of a child before the brain is done developing, in my opinion, and in most cases, there's nobody on the planet that can 100% say that that person's going to have this for the rest of their life. Okay? Nor is there any neuroscience to prove that. Now, there is, I'll say this, well, if a kiddo who is age 6 with really mild ADHD, but they do have it, I would say they've got a pretty decent chance of growing out of it, because the frontal lobe won't be done developing until age 25, and certainly with intervention and medication, the right medication, they probably will. As compared to a kiddo at the same age with, let's say, a prenatal history of being exposed to, crack cocaine and methamphetamine, and also had, severe epilepsy that was untreated, or not I say untreated, that was irretractable epilepsy during early childhood, which affected the frontal lobe. If we've got those factors on board and a severe form of it at that age, I can't 100% say so, but I would say there's probably a 95% chance that person's still going to have ADHD as an adult. You see the difference there? Okay.
Yeah, but there's a lot of hope in that.
Oh, there's tons
with the mild form that you said, and the
Mhm.
frontal lobe not being developed, and and 25-year-old, all that just seems very hopeful for people. I like that.
Oh, absolutely. And that's the thing, is that and that's not just for ADHD, by the way. It's for everything else we're going to talk about for this whole class. Anything that's diagnosed in the brain as a psychiatric illness in kiddos, the younger they are and the milder it is, and the sooner we get intervention and treatment, the less likely it's going to be something they have to deal with the rest of their life.
That is probably the best news I've heard all year. Well, we're not very far into it, but that is huge. Thank you for saying that, because sometimes you go through all of these classes, and probably Sarah would know it the best because she's furthest along. Some of this can be very overwhelming and just feel like, oh my gosh, what am I getting into? Right. But this is so hopeful what you're telling us. So thank you.
Absolutely. So working with, and that's the thing is, does that mean it's not hopeful working with adults? No. And in fact, um, even though the same principle applies for adults, you have a better chance at the more consistent they are and compliant, and the higher the quality of treatment that they get, it's more likely to suppress it long enough that it becomes increasingly less probable that the symptoms are going to negatively affect them. So
I have a
here, so
question.
we've got, yep,
Doctor,
real quick, let me say a
Okay.
couple. So we've got the pathophysiology of all these diagnoses is one thing, but you can have the pathophysiology of it occurring in the brain without the symptoms causing dysfunction enough to make a diagnosis, just so you know.
So this is such a basic question. Are you
Sure.
actually implying or saying that you can sort of rewire the brain? Like
I don't really like that.
rewire some pathways to allow better, I don't even know the right word, sorry, functioning, or I don't know. This is just huge, all of this.
For simplicity's sake, I'll use the word rewiring. I'm not a big fan of using that word only because it oversimplifies it. But what I would say is, yes, in treatment, both from a therapeutic standpoint, like counseling, psychotherapy, and from a medication standpoint, when done correctly, helps the brain develop healthier signaling or rewire itself in a healthier manner, such that it decreases the probability of an individual either having enough symptoms to make a diagnosis, or it decreases the probability that it will cause dysfunction to their day-to-day life, or it decreases that kid's probability that they're going to have the rest of their life. Yep. All right. So for the sake of time, I'm going to jump into talking about how do we define ADHD and treat it and evaluate it, because really and truly, if I want you to get anything from the neurodevelopmental chapters, is I want you to feel pretty good and confident about what needs to happen when you suspect that you're working with a kiddo with ADHD. Okay.
Excuse me, really
Mhm.
quick, would you please let me know which week is these slides in? Because I'm trying to print them. I like making notes on them.
Yeah,
and I
so it's
couldn't-
week 2 PowerPoint slides, and then I think it's week 3, maybe the ADHD stuff.
Okay. All right.
Mhm.
Thank you.
All right. So ADHD, it's all over TikTok. What you need to know is that it's a neurodevelopmental disorder that begins in neurodevelopment from a pathophysiology standpoint. That doesn't mean it has to begin from a symptom presentation standpoint during neurodevelopment. That's why we have what's called adult onset ADHD. If somebody is an adult with adult onset ADHD, that means they had the brain of an ADHD kid, but for whatever reason, their symptoms did not rise to the degree either to be significantly noticeable or memorable or in need of any kind of intervention. But all of a sudden they're adults, they went to grad school, whatever it was, and life became more than what they were able to compensate. And so now their symptoms emerge, even though the pathophysiology had been present the entire time. Okay. ADHD and all neurodevelopmental disorders imply that we've got the pathophysiology present. Okay. And that if it's a child, that pathophysiology is causing them dysfunction in either their social, like relationships, their academic achievement and performance, or their functional, like age appropriate acquisition of activities of daily living, like you know, tying their shoes or potty training, or somebody's got a bird squeaking. I think we got you. All right, good. So now ADHD is a disorder that negatively affects the developmental developmental trajectory of the wiring of the frontal lobe and the dopamine system. The frontal lobe functions include things like judgment, social skills, mental flexibility, taking initiative at an age-appropriate level, sustaining initiative, focusing, concentrating, planning, prioritizing, organizing, impulse control, and very importantly, mood regulation and response to stress, in addition to a whole bunch of else, okay? But that's what the frontal lobe does. When I say the frontal lobe's not done developing, it's the wires, though, from the frontal lobe throughout the rest of the brain that aren't fully developed. Those wires, the axons, that's what they're called, those wires communicate with the rest of the brain using dopamine and norepinephrine primarily. Those are the neurotransmitters. ADHD, everybody with ADHD brains, they have enough dopamine and norepinephrine. The chemicals are there. What they don't have, I say what they don't have, what we don't have, because I've got ADHD. What we don't have are enough of the receptors so that our brains can use what we have. And so where everybody else has, let's just say, like 5 dopamine receptors, and this neuron's trying to talk to this one, and it shoots out 5 dopamine molecules, this one has 5 receptors, and it catches all 5, and it continues the message. But people with ADHD only have 2. And so what happens is this side releases it initially, and actually really what happens is this side has enough, but it only shoots out 2 signals because it knows that there's only 2 receptors on the other side. And when there's only 2 little molecules going around it out here, a lot of times most molecules don't find their way to a receptor, and they never dock officially. And so the messages don't get sent on. In other words, when you do that, when you multiply that by 1 trillion different times, some of them working, some of them not, you get inefficient processing that's happening from the dopamine frontal lobe, and I'm sorry, the dopamine norepinephrine frontal lobe wiring throughout the rest of the brain. And not to throw us off topic, but real quick, but it's not just the brain. It's the rest of the body too. And in fact, just to deep dive real quick, ADHD and autism specifically, and OCD, schizophrenia, Tourette's, tic disorder, and bipolar, all of those are also whole body things. They're not just brain problems. They're whole body things, and which is why you will, if you work with any of these populations specifically for long enough, and I have with ADHD for a while now, you will see that there are patterns of physical illnesses that go with these things. And ADHD, for example, dysautonomia is really common. I don't know if you've ever heard of that before, but dysautonomia is literally just translated dysfunctional autonomic nervous system. So like usually it relates to having like weird heart rhythm abnormalities, weird blood pressure fluctuations. A lot of times they're passing out. They might have POTS. That's another syndrome. Weird like peripheral neuropathy, digestive issues, bladder issues, balance issues, sensory processing issues, all kinds of stuff. And that's because everything I'm talking about a while ago with the dopamine norepinephrine system, that's also true throughout the rest of the body. Now, technically, you don't have norepinephrine used in, you don't have like norepinephrine used in your peripheral system. That's just a central nervous system neurotransmitter. But and that's only because we are semantically saying norepinephrine there, but chemically it's the same thing as noradrenaline and epinephrine. Has anybody ever heard of an EpiPen, right? Yeah. When you're allergic to something, you get shot with an EpiPen.
Yeah.
Mm-hmm. That epinephrine is same thing, almost exactly identical to norepinephrine.
Wow.
In fact, what happens is epinephrine gets metabolized into or turns into norepinephrine once it goes through hydroxylation or whatever it's called. Yeah, first pass metabolism. Anyway, with ADHD, that system being slower processing, there are many things that can cause that system to have slower processing from a genetic standpoint, being very predominant, meaning that you're born with the blueprints, and your brain's like, all right, so how many dopamine receptors do we need to build? Well, as a baby, it's looking at the blueprint saying, well, we've got, mom says this, dad's genes say this. Okay, let's do that. Let's start there. Which is why ADHD ends up being about 60% explained in most cases by genetics. Now, that system, even though it might be genetically inherited as blueprints, doesn't mean that that's forever. Again, all that is the starting point. Because once it takes the blueprints, like, all right, we just need the framing of the house, because we're going to build the rest of this house for like the next 20 something years. So we got time, but we've got to have a skeleton, right? That's what the genetics do. The other things that can disrupt or teach the brain not to have enough of those dopamine receptors is prenatal exposure to any sort of complication. Now, it's not 100% certain, but in general, the more severe it is, whatever it was, whether that was, exposure to alcohol or mom had a car wreck while pregnant, whatever it was, the more severe it was, or the more it affected that person while in utero, the more likely it added an addendum to those blueprints of genetics. So we turn the page and says, okay, but also you need to do this. Okay. From there, oh, and by the way, just real quick, this is important. It's almost 100% certain that if mom smokes while pregnant, that baby is going to have ADHD. Okay.
That's so sad. I know that they put warnings on everything now, right? That it can affect a pregnancy. But that is like a big, gigantic thing for, I would think, for a mother to be to know. They don't say that on the packaging of. That's wrong, I think. Sorry.
Yep. I completely agree. But that might also be the case for Tylenol, just so you know.
What?
Yep.
And I thought Tylenol was the preferred thing that was supposed to be the least risk when you are pregnant. They tell moms you can take Tylenol. Right? I mean, for anybody else who's a mom, I remember that was supposed to be the safest.
Yep. So here's the thing. What you need to know, and this is really where medicine has failed our society in educating us, in the sense that medicine historically has had to oversimplify what they communicate to our society, because there was such a gap between knowledge base, where we had doctors and then, you know, people that were not doctors had no idea what they were talking about. And so what's happened is they never changed that methodology in their educational process in any way. Because the truth is that there's a lot of different things that can affect and increase the risk of birth defects and having long-term implications. But a lot of times it's easier, because the odds are so small, to just say, no, it's safe.
Wow, what a disservice.
I mean, and here's the thing, I am pro medicine, if anything, because I'm not a fan of the anti-medicine like movement, because I know doctors that are working in the trenches getting death threats from, you know, anti-COVID, like, you know, people out there politically, whatever it is, like, who are saving the lives of those same people. And so I'm all pro medicine, but you need to know is that you can't take that stuff at face value. You need to really do your due diligence and research there before you communicate anything to your patients, especially. Somebody raised their hand.
Yeah, it was me. I wanted to go back to when you said the ADHD. It's 100% chance that if mom smokes, then you know, the child would have ADHD. Do you take that in account? Like back in the 60s when I was born, mothers smoked. There were no warnings. And so do you think that takes in account of a lot of the adult onset of ADHD? Because again,
that's a
been in my
huge
50s,
question.
yeah.
I always ask that, because that culturally back then, that was the norm. And it was still true back then. It's just that I know that if it's pretty clear that happened and occurred in an adult, that we've got a pretty good chance that we have ADHD.
Yeah. And then, you know, people in my age group, we weren't diagnosed with ADHD growing up. There was just not. So yeah, I just wanted to ask about that. Okay.
Yep. And people people in my age group out in the rural areas, even if you had it, you didn't get diagnosed with it. You just got arrested and, you know, thrown in jail. So
that's awesome.
That it's and it's still kind of the case today, especially for minority populations, which is unfortunate. So let me say this to speed us up. ADHD affects the frontal lobe functioning because it prevents the frontal lobe from actually getting the brain to do what it needs it to do, which is all those executive functions. Whenever I say the frontal lobe, like executive functions are localized right there, the programming is localized right there, but we need the whole brain in order to do an executive function. In order to like use good judgment or have impulse control, you really need the whole brain working together to do that. It's not just the frontal lobe. If you only had a frontal lobe, first of all, you wouldn't even be here, right? So in other words, I want you to think about it this way. It's the communication from the frontal lobe to the rest of the brain that's disrupted. And the longer it stays like that, the more it wants to stay like that. And the other pieces that can cause ADHD, anything after birth that significantly disrupts the physical functioning of the body, like a chronic disease, for example, childhood diabetes, seizures, like recurring seizures in early childhood, not like febrile seizure stuff. Chronic illness, trauma, psychological trauma, or exposure to chronic stress, exposure to heavy metals, particularly lead in the water, not lead, and mercury as well. Having any kind of chronic medical condition, and keep in mind sleep disorders, particularly sleep apnea, which goes underdiagnosing kids. All of those things, even though they're primary like disorders in other ways, physically, they affect the frontal lobe functioning, because the frontal lobe is the most sensitive part of the entire brain in relation to its response to the environment. Remember, the frontal lobe, it's developing, so to speak, and the way it does that by the input from its environment. And so if we are chronically sick as a kid, meaning that we're not getting enough social stimulation, or we're not getting access to, enough cognitive like challenge or even emotional support or whatever it is, or we're not sleeping well, or, we're in chronic pain, all those things are teaching the frontal lobe what its norm should be. Does that make sense? Okay.
Does that
Now,
apply for older people too? If you look at the other end of the spectrum, if they don't stay engaged and exercising and whatnot, does that show up on the other side too of our lifespan?
not in the same way, because this is when it happens during childhood chronically, during childhood, because that the framing is still being built.
Okay.
As compared to adulthood, where the whole house has already been built. Now we're talking about making the if we don't keep up the work with the roof, the maintenance, we're going to start having some holes in it. Does that make sense? And it's a
Yes,
different
thank
thing,
you.
because one is programming, and it's really what we're talking about is epigenetics. That's the term that we're shooting for there. Okay. All right. ADHD is characterized in the DSM-5, and it drives me bananas so incorrectly, but we've got inattention, difficulty concentrating, focusing, resisting distraction, whatever it is. Also, we've got symptoms of hyperactivity, where, we can't sit still. There's like restlessness, so forth. And then impulsivity, where just doing things without thinking, blurting into conversations, or impulse buying at Walmart, stuff like that, right? So that's classically how the APA has defined ADHD, whereas the truth is ADHD is an executive functioning disorder, which sometimes includes those three things, but often might not include any of those things. I know it sounds strange, but you can have ADHD and not meet the diagnostic criteria in the DSM-5 simply because it is contextually, I would say this, our symptoms of ADHD are context dependent. So if you put me here in, in front of teaching a class, although it might not seem like it, I can concentrate, I can stay present and even hyper focus. I can be efficient in my cognitive processing, I can knock it out of the park across the board. And during that, and in that context, I'm not going to meet the diagnostic criteria. Right? Because it's interest dependent. And that's the thing that I want you to remember, is that all the symptoms of ADHD are interest dependent. It doesn't matter if it's a 3-year-old or a 99-year-old. So they have difficulty paying attention sometimes, or they might have difficulty paying attention, but seemingly when they're interested in it, they don't. That's where you see kids, hyper focused on a video game they're playing, right? And somehow you can walk in front of them and they've got like this x-ray vision. They don't even move. They're not blinking. Their eyes are all dry looking, and they're still playing it, and playing it well, usually. That's the hyper focus, and that's paying attention, but it's interest dependent. And when I say interest dependent, breaking that down to make this even more applicable to what you're doing in therapy, this is important to note, especially as you communicate it to parents. Interest dependent means reward dependent. I can get the most defiant 6-year-old on the planet. I could get them to write a dissertation for the right amount of American money. What I mean by that is, if I had it visually in front of them, like a stack of $100 bills, you can motivate anybody age 3 to 99, I promise, in the moment to do whatever it is. Usually there's a dollar sign there. Like most kiddos, they won't want to, pay attention in class or whatever it is, but I promise you they would if we looked at what kind of Fortnite skin that they are obsessing about and daydreaming about, and have parents use that intentionally as a reward in the here and now. So here's the thing, and this is true for everybody, not just ADHD, what I just said and what I'm about to say, but for those of us with ADHD, we've got to have the reward in the here and now. You cannot, and it won't work for me to say, hey, kiddo, here's $1 million. You'll get that at the end of the week if you can write me, 5-page paper on whatever. It doesn't matter if it's $1 million or not. They're not going to be motivated or remain motivated because of how far off or temporally that reward is set. Because the ADHD brain, because we only have the 2, receptors over here, we need either like an exciting experience to release a ton of dopamine, which is why we're all sensation seeking, or we need the ability, I would say, we need a short duration pulse. So instead of like a stream of like low grade, like communicating dopamine, we need like a short duration, just one off. That short duration, in other words, is the immediacy of the reward. And what we seek when we try to sit down and do something that we're not interested in, and I'll just tell you subjectively what it feels like. It feels like you do when you're cognitively tired at the end of the day, right? If you ever had like a long day and you just sit down, you're just like, you know what? I'm just gonna turn my brain off for a little bit, sit here on the couch, be quiet. Yeah, I'm tired. That's what it feels like for those of us with ADHD trying to do something we don't want to do. And at age 5, I'm telling you, the 5-year-old brain is not designed, first of all, to sit down in class and learn something, but especially if that's something that we're trying to learn, takes a whole lot of cognitive effort. That's the other side of that equation. The more effort it takes to earn a reward, the less gas we have in our gas tank to focus on it. Okay? And effort is directly tied to, I would say, well, capacity or capabilities, but also the reward. So if the reward's not strong enough, so as an example, if the reward is not enough, it's going to take more intrinsic effort or motivation in order to accomplish that task. And the more it takes on that front, the less likely it's going to happen. And that's the dysfunction of ADHD. And that's true for not just paying attention, but it's also true for planning or prioritizing a task or impulse control. I'm telling you, kids that play video games with ADHD are better than adults at impulse control when it comes to the timing of whenever they hit those buttons. I promise. They're great at it because it's all context dependent. Okay. Speeding this up a little bit. ADHD treatment is a combination of a couple things. Actually, yeah, let's talk about treatment. We've got one very clear research and data, and if you ever want to talk more about this or you're wondering the validity of what I'm about to say, I'd be happy to explain it later. When it's done correctly, medication is the most effective approach. And when I say medication, psychostimulant medication, which includes things like Adderall or amphetamine, and the other stimulant, methylphenidate or Ritalin. Okay? It's okay if you don't agree with that. We can talk about it later.
Is this more for the person who has the hyperactivity part of it, or the one that's just more of attention deficit?
It is for both.
For both.
Mm-hmm.
Okay.
Now,
what if
there
that
are
child
reasons.
also has, I'm sorry, go ahead.
I was going to say there are reasons. Well, I'll say this. On average, those are the best options for both.
Okay.
But there are several reasons why a non-stimulant might be a better choice for a lot of kiddos with ADHD, depending on their symptom presentation and other comorbidities.
Okay.
So,
So
for
like
example,
if a child also has anxiety,
Uh-huh.
if a child also has anxiety, would the stimulant be better or the non-stimulant? So is that kind of what you're talking about?
That's a great question. And that's kind of the classical overall idea, is that the stimulants ramp up anxiety. But the truth is, and this is where we're going a little bit more advanced than even what this class really should go, but I'm happy to share it. Yes and no, and it depends on the kid, depends on what type of anxiety we're talking about. It depends on how they're sleeping, because a lot of times stimulants can treat anxiety more effectively than a non-stimulant can.
Okay.
I know it sounds bizarre, and it kind of goes against, hey, Bubba, okay. It kind of goes against everything that you kind of hear or read about, but the truth is that when it's done correctly, in some cases, but the challenge is we don't have any great way of pinpointing or predicting what subset of the population would be treated most effectively with a stimulant, and if they have anxiety. Hang on one second. Hey, Bo. All right. You good? All right. Thumbs up. My 5-year-old. Whoa. The 5-year-old son just gave me a wink and a thumbs up. Just then. So we're good. But so we've got the psychostimulants. And those, like I said, include the amphetamine derivatives and methylphenidate. What you need to know about those, long story short, amphetamine was first. Then parents didn't like the word amphetamine anymore. So Big Pharma was like, okay, well, we can fix that. We created methylphenidate, which does almost exactly the same thing as amphetamine, has same side effects, just think of it as the same thing. Methylphenidate is the same thing as amphetamine. The parents didn't know what methylphenidate was because that sounds better than amphetamine, so that we keep our sales up. Make sense? And that's not, I'm oversimplifying it, but what you need to know there is that those are the stimulants. And when those are done correctly, what the research supports is with an accurate diagnosis, the right medication that's monitored and adjusted appropriately, that helps the frontal lobe develop more normally into adulthood and probably decreases the chance of that kiddo having to take medication the rest of their life, and probably decreases their risk of having or meeting the diagnostic criteria for ADHD the rest of their life. So it might enhance their ability to grow out of it, in other words, which is cool. We don't see it done correctly very often because it's diagnosed by non-specialists, right? Based on a parent and a teacher questionnaire that has a white, checkbox if you want your kid to have ADHD, and a gray one if you don't want them to have it. And all you gotta do is like, well, I want my kid to have it, so I'm gonna check all the white boxes. Okay, yep, they got it. Let's try some Ritalin. That's a terrible way to diagnose it. And those same people diagnosing it that way are prescribing these stimulants based on, usually about a 4-week experience rotation in residency or their internship in psychiatry, because it's usually pediatricians, general practitioners prescribing it. Nothing against them, but they just don't have the training. So my point there, just because there's negative connotation around those words like Adderall and amphetamine and Ritalin and so forth, try to separate yourself from the negative aspects of that and think through it chemically and what it relates to the biological side, because the reality is we're going to have tons of terrible side effects and zombies and all kinds of stuff that's going to be bad associated with it when it's done incorrectly, either diagnostically and or from a treatment perspective. Okay. So most of what you've seen on the negative side is the result of not having enough people knowing how to diagnose it or how to prescribe this stuff effectively. If a kid turns into a zombie on stimulants, it's too high of a dose or too low of a dose, or it's the wrong type of stimulant, because that's not the outcome we want. We do not want to lose their personality. Okay. The question is, does medication always need to be necessary? There is no research to support that it's not always beneficial, but there's times that it might be contraindicated, meaning if we've got a kiddo with severe heart rhythm abnormalities, a stimulant is probably going to be not a great option. Or if we have a kiddo with severe OCD and Tourette's, a stimulant might not be the best option. But in most cases, a stimulant is the best option. There are also non-stimulants, and I don't want to not highlight those as much as the stimulants. It's just that you need to know is that the research doesn't support their efficacy as much as they do the stimulants. And the non-stimulants include things like Strattera, Intunev, which is guanfacine, Catapress, which is clonidine, and the new one, Viloxazine or Quellbri. And what all of, well, not what all of those do, but what Strattera and Quellbri do is they boost norepinephrine and indirectly enhance dopamine output. And they don't do it as well as stimulants do, but they do it to some extent. They're more like, if you've ever heard of Pristique or Effexor antidepressants, they're almost identical to that. Yeah. Or even Prozac. Prozac's almost identical to Quellbri, by the way. Guanfacine and Intunev, those are blood pressure medications, believe it or not. And they're primarily used for ADHD because they indirectly increase the metabolism or the blood flow to the frontal lobe and essentially allows for the more release of dopamine and norepinephrine, with the hope that if we do that enough, it will teach the other side to grow more receptors. Okay. In kids, most of the time, parents and pediatricians want to start with a non-stimulant because it just sounds better. I mean, that's just, I'll be honest with you. Parents want to start with a non-stimulant mostly because it sounds safer. And if they actually knew all the ins and outs medically, they would know they're not safer physically. They're actually less safe than the stimulants, but they want to start there. And it's not a bad idea to start there. Because, I mean, if we don't have to, if a non-stimulant is enough, just functionally and practically speaking, it's just a whole lot easier for the prescriber and less taxing on the parent to have to deal with all the DEA regulations around that Schedule II drug, the stimulant. But the non-stimulants are also usually beneficial if we've got trouble falling asleep at night for kids. Especially if we prescribe the non-stimulant at night, it can actually help them fall asleep. And if we've got pretty significant anxiety, a non-stimulant isn't a bad option to consider because they're less likely to cause or ramp up anxiety in the same way that a stimulant might increase it. And on top of that, some of these, like Strattera and Quellbri specifically, those are used off-label to treat anxiety and depression and OCD. And so you could actually tackle several different diagnoses, including ADHD, with just one medication versus the stimulant, which primarily and in most cases is only going to treat the ADHD. And Donna, you had a question?
Yes, on your chart deck, it's kind of colored in blue. It's further down in the slide you're on. It looks like a whole bunch of medicine names. Are these some of what is used to address ADHD? It's okay. And then
I've got it pulled up right now. Is that what you're talking about?
Yes, sir. And so thank you. I'll look at that later or print it out because it's hard to kind of read tiny like this. But the other question is, counselors obviously don't prescribe this medicine to their clients. It would happen through a psychologist or an MD, correct? It'd
be a psychiatrist, which are they're either MDs or DOs,
Okay,
or a psychiatric nurse practitioner,
okay,
or a pediatrician. That's actually in most cases, that's who is prescribing it. Or a physician assistant who works for one of those people. In the state of Texas, anyway. So in other states, some psychologists can prescribe if they've got the training that I do. In Texas, I can't, but like in Louisiana, if I lived in Louisiana, I could be only doing, prescribing if I wanted to. But psychologists, for the most part, don't have the training to even close to think about prescribing. And that's different than psychologists or PhDs or PsyDs. Psychiatrists are MDs or DOs. Yep. All right. So going back real quick, and I'm highlighting the medicine because you guys are going to be asked by parents. Hang on, let me find where I was. Yeah. You guys are going to be asked by parents much more so than they will talk to any of their doctors about all this stuff. And they're going to expect you to know it. Like, that's the thing. And even if you don't have experience with it, that's okay. What you need to know is that there is great information provided by psychiatry on all this stuff, but it also isn't up to date. It doesn't stay up to date the way it should. And I'll give you an example. The DEA regulates the maximum dose for scheduled compounds. So that includes Adderall, Ritalin, and so forth. The max dose from a clinical standpoint is typically outlined by the maximal response, of symptom, like how much is this medication helping with symptom remission, and in relation to the amount of medication in the blood supply, in the blood stream. Now, with the stimulants in particular, what we now know is that most of what we know or what's listed out there as the max dose is based on the DEA setting a limit of what that max dose should be as compared to what the actual clinical max dose is. So Concerta, for example, I think the max dose is like 72 milligrams or 80 something. I can't remember what it was, but per day or whatever it is. The reality is only about 60% of all kids with ADHD are going to be effectively treated at that level, or at that level or below. So there's 40% of kids with ADHD that won't see maximum effectiveness of treatment ever, because the DEA has set just an arbitrary cutoff point. And I'm not here to tell you, like, I wish we would just, dope our kids up. That's not what I'm saying at all. What I'm saying is that there's a cultural and political perspective on this stuff that is not science-based, and that which is continuing to interfere with treating this stuff as maximally as effective as we could be. And you need to also know, amphetamine does not equal methamphetamine. Methamphetamine used to be prescribed a long time ago. Methamphetamine is about 1,000 times more cardiotoxic and potent, and is not good for you. Amphetamine is a lot cleaner. It's literally, once methamphetamine goes in the body, gets processed by the liver, it turns into amphetamine because the liver cleans all the bad stuff out of methamphetamine and turns into amphetamine. I'm not saying amphetamine's safe for everybody, but physiologically it is safer than the antihistamine that you take over the counter. Yeah, I know it's wild. Anyway,
Yeah, that's huge what you're saying.
so behaviorally, on the flip side of this, as therapists, what I want to highlight is, one, what I tell parents is I'm never going to push you one way or the other. You know, your kid has to get medication. That's the only form of treatment that you can, that's the only option. If you don't do that, you're a terrible parent. I'm never going to do that. I'm never going to do that. First of all, that's a good way to lose your license because you should never do that for any treatment. But secondly, is that even though the research hasn't been real positive, and that's being kind, hasn't been real positive about behavioral intervention for ADHD and its effectiveness, what I do know is that we've got a frontal lobe that is just twiddling its thumbs, wanting the environment to teach it how to be healthy and how to develop healthy pathways. And we'll have that frontal lobe in that child until they're 25, right? So anything that we do to intervene environmentally, which includes either that 1 hour in counseling or play therapy, whatever it is per week, and or includes some other systemic intervention at home or at school, or all three, ideally, that's time spent molding this frontal lobe in a healthier manner. And so it might not undo the pathophysiology of the frontal lobe, but it certainly will help the other factor of what shapes the frontal lobe's trajectory by serving the frontal lobe to push it into a healthier state into adulthood. Because what you need to know is the medication, when taken in childhood, it makes the frontal lobe develop more normally, but it's not the medication itself. It's just that we've got, you know, little Johnny now with ADHD. He's not punching all of his peers in the face anymore. And so his frontal lobe's able to be shaped healthier because he's got social relationships now. Whereas before he didn't. That's what I mean by behavioral intervention, is that if we can, the more time that we can, in a healthy way, approach that kiddo's frontal lobe and teach it executive functioning stuff at an age appropriate level, the better we're gonna be as far as how does this affect us functionally. Okay.
I'm taking this in because as a school counselor, which is what I'm wanting to do,
Right.
that just tells me, that just validates the idea that we need to have systematic approaches in school that are helping teach our kids.
Are you trying to get on my good side? Because yes, I'm right there with you.
I'm a believer.
Yep. Because here's the thing, 1 hour a week with a kid, and even an adult for that matter, I mean, it's hard enough for an adult. But the difference is when you work with kids and the younger they are, you get 1 hour in shaping their frontal lobe. Adults can shape their own frontal lobe by their own volitional choices, depending on their capacity to do so. Right? You can teach an adult how to deep breathe for panic attacks and keep them accountable for using those skills in the real world, rather than a child. The younger they are, you can teach them all the skills in the world, but you're still going to need to be there to say, hey, it looks like you're a little bit hangry, buddy. Let's get you a snack. Right? So we've got to set the system up whether it's the parents, caretakers, guardians, and the school as well. And the challenge on my end that ends up what I get frustrated with is, especially as it relates to ADHD, is there's so much misinformation out there, and it seems like our culture is behind in really understanding it. And it's not, it's seemingly so common and cliche now that it's kind of dismissed, because everybody's like, but I also had a little bit of ADHD when I was a kid, and I didn't have those same problems. My parents just would discipline me, and I figured it out. That is not knowing what they don't know, and the literal definition of just ignorance, because the truth is, not everybody has ADHD. If it is a correct diagnosis, that kid is going to be behind socially, emotionally, executive functions, all or some are going to be behind by about 2 to 3 years as compared to the age-matched peers. Even if you've got a gifted kiddo that's 11 that academically can outthink a 20-year-old, if they have ADHD, a lot of times they struggle socially because guess what? Social skills are located up here. Or you'll have a kiddo that relates better with younger kids and adults only, but not, say, age-matched peers. That's a common thing that you'll see with ADHD, because the younger kids are more closely aligned with what their actual social emotional age is. And then the adults are a lot more predictable. It's easy to relate with an adult because an adult, isn't like staring at you, making weird faces while you're talking, as their peers would. I don't know if you ever had like conversations with like 9-year-olds and you try to make a joke in front of them, and they're just like, they're just like, I mean, if you're self-conscious, just trying to talk to a little kid will make you self-conscious. That's what it's like being a kid. They're trying to talk to other kids who are not real great themselves at communicating. And so it's a lot of open-endedness for ADHD kiddos. But my point is that if you can remember this, is our job and goal as a counselor working with kids and parents is, first, you got to know that I always recommend getting parents and caretakers, guardians into the session every single time, at least for part of this therapy session if you have it. Because if you don't do that, the only thing you're doing is spending, 15, 20, 30 minutes or 5 minutes if you're a school counselor shaping the frontal lobe as compared to the rest of the week. How much is shaping the frontal lobe outside of that time? Okay. If you're working with the kiddo at an age appropriate level, think about it this way. It's not just chronological age, but if they have ADHD, I want you to subtract 2 or 3 years off their social emotional development and think and conceptualize their subjective experience cognitively and emotionally at an immature level compared to their age. When you do that, it'll help you set realistic expectations of what might be a better approach, and we've got to be more concrete in how we explain this to them, or helping them process things through play therapy in a way that's more appropriate for a kid that's 3 or 4 years younger. Okay. It's also true for a 20-year-old, by the way, with ADHD in most cases. It's also true. It's also why 16-year-olds with ADHD, and a lot of times, don't want to drive. You'll see them not driving until they're like 18 or so. Yep. Or not moving out of the house till they're 20.
And then you have some who, because I'm currently a high school counselor, but you have some that opt to get off of their medication and they start self-medicating.
Yep. And that's the other thing about the medication real quick, and I'm glad you brought that up. There's a decreased, it's like 10-fold decreased chance of self-medicating with substances, illicit substances, if a psychostimulant is used as the primary form of treatment in kids. So parents are always like, well, I don't want them to get, I don't want them, we've got substance use in our family history. I don't want this to be the gateway. No, they've got the gate's already open. If you want to close that thing, you need to give their brain what it's craving. Because in a controlled way, and in a healthy way, in a predictable way, as compared to all the other stuff that they're gonna be drawn to self-medicating as it is, this is gonna decrease their chance of doing that. So anyway, I know we're gonna have to wrap up, and I know, gosh, we still have not gotten out of ADHD, but the good news is that you guys are learning the fundamentals of our next conversations here, but let me highlight a few things and I'll take a few questions and we'll wrap up. Okay. If I could, here's my hope. My hope is that you hear all this stuff, and for the school counselors out there, or even for private, the professional counselors and LMFTs, I want you to hear all this stuff, and I want you to recognize that we've got a world that is not conceptualizing ADHD correctly and is not labeling it as a physical or neurological disability in the same way it would like a brain injury, right? Because of that, we've got a world that sets expectations for kids with ADHD that's well beyond what they're neurologically capable of. Now, the point of development, the way we develop and learn, the whole, idea behind education is, Chomsky's zone of proximal development. As parents, even, we're trying to push these kids constantly just beyond where they're at currently. Because by challenging them incrementally like that, we start to learn and gain cognitive skills, academic skills we develop. That works for the most part for kids who don't have ADHD because we're setting realistic expectations. But that level, that's only that gap for kids without ADHD, might be that gap for a kid with ADHD. Does that make sense? In other words, we need the world to understand what this is. And I say the world, that includes the school systems and parents and other clinicians even, that really understands what's realistically what's realistic in age appropriate functional independence when it comes to executive functioning. Because without that, it's a whole lot of, well, it's probably not, they're just, they know how to pay attention. I've seen them play video games before. And that shaming, I'm telling you, is the toxicity that only exacerbates this problem as they get older, and especially into adulthood. And then secondly, the other thing I want you to remember is that you as a therapist, if you're going to work with kids with ADHD, well, I'll say if you're going to work with kids, get ready, because you're going to work with a whole lot of ADHD, whether you want to or not. And so it's going to be imperative for you to become an expert on the word executive functioning. Because once you know that term inside and out, especially as it relates to age and how executive functions develop with age, the better you know that stuff there, the better you're going to be able to take all these techniques that you're learning in grad school and your training and apply those to ADHD specific populations. Because here's the thing, for a 14-year-old or a 15-year-old, you know, there might be a CBT based approach for anxiety, right? And that's assuming they don't have ADHD. That approach is not going to work with a 15-year-old with ADHD and anxiety, because what you're trying to do, you're approaching them as if their frontal lobe is the same age, and it's not. And so you have to adjust how you tailor each of your interventions when we have the presence of ADHD, depending on the kid's age. Yes, ma'am.
This is making me think about just even in some of the multicultural that Amberton is teaching us, that a lot of the philosophies and tests and research has been slanted towards one demographic more than others. And so it's like a lack of awareness. I did not realize what you taught today was invaluable. It was beyond awareness. It was actually creating some empathy in my heart for wow. And people who struggle with this. Wow. I mean,
it's a neurological disability that is underrated as it relates to its lifetime effects beginning in childhood on relationships, academic achievement, social skill development, vocational attainment, quality of life, physical functioning, and even longevity. ADHD, just so you know, it's correlated with like 10 times untreated ADHD is correlated with 10 times increase at least in severe motor vehicle accidents. Untreated ADHD in childhood is related to almost 100-fold increase chance of incarceration as an adult.
really? Wow.
I've never met anybody in prison that doesn't have ADHD.
Wow. That just makes my heart sad.
It does. I mean, and here's the thing, the courts don't care about any of this stuff. Like, and I'm not saying that people shouldn't be culpable for crimes, but yeah, long story short is that ADHD, and I'm going to throw you a curveball tomorrow and this is a good segue to wrap this up, but I keep saying ADHD. I actually don't even like that diagnosis anymore. Like, I don't like that label because it's such a confined label by the APA now, where reality is neurodevelopmental differences, or really there's a frontal lobe developmental syndrome that has probably 100 different subtypes, one of which might include predominantly ADHD subtype. The other subtypes would be predominantly autism subtype, or predominantly OCD subtype, or predominantly bipolar subtype, or so forth, or antisocial subtype. Like, it all ties back to the same pathways we're talking about here, which is why I'm spending so much time talking about it, because when we talk about depression and bipolar, and we'll talk about DMDD tomorrow, we're talking about the emotional regulation side of this thing, which, guess what, is primarily controlled by the monoamine neurotransmitter system, which is dopamine, norepinephrine, and serotonin. Okay. Cool thing is if y'all are going to work with kids, and I'm assuming you are if you're in this class, at some point, well, I guess you could only want to work with adults, and you have to take this class and the other one for your counseling stuff. But anyway, if you're going to work with kids, the good news is that a little bit of intervention goes a long ways with kids. It's just like medicine, like the smaller the dose works more effectively in kids than a big dose does in adulthood. And not just that, you are literally changing their life, like giving them years. You might even be giving them years of life, like actual living. They may actually live longer, like because of what you're doing. And so it's hard work because the kid is the person that you're trying to treat, but you've got so many variables that go into producing the behaviors of why the kid's seeing you in the first place that also need to be treated along with the kid. Some of it is societal and cultural, which we need to continue to shape as professionals and not let non-science stuff shape it. And then the other part of it is our own perspective and understanding. And you're not going to know it all, and I certainly don't know it all. But with all the neurodevelopmental disorders, it's going to be important for you to stay on top of the research moving forward, because it's coming out quick and hot right now, because it's the new cool thing. Yeah. All right, questions?
Yes, I did look at week 2 and week 3 before I ask, but I don't see these particular slides. Maybe it's me. I haven't had my coffee, but can we make sure, please? Because I really want to go through all these slides.
It's in there. I printed it off this morning.
It's in week 3 is the advanced assessment of ADHD.
Okay, week 3.
It's right under executive functioning textbook resources and right above the week 3 quiz button.
Okay. All right.
Did you find it?
I'm looking right now. I thought I looked at it and it wasn't, but
Oh, here, I can do. Let me do this. I'll share my screen. There we go.
okay, let me go back to now I lost the Zoom. I apologize. There we go. Okay. Okay.
Can you see my screen?
Yes, I can. Yes, sir.
So it's right underneath this.
Yeah.
Moodle, right here.
Okay. I had thought it looked different. Maybe again it's just. Let me see. Yeah, there it is. Okay, I apologize.
No worries. We're good.
So we're meeting tomorrow, and then you'll move into week 4.
Yes. So
Those are the
we'll talk.
slides.
We'll talk briefly about psychosis. I'm sorry. We'll talk about autism tomorrow. And good news is, guys, we talked all about ADHD. What I meant by saying I don't like the ADHD term is because you already know almost all there is to know about ADHD, autism, OCD, Tourette's, and bipolar. We'll talk more about those, but everything we talked about, that's the same phenomenon. We'll get there down the road. But tomorrow we'll talk about autism. We'll briefly cover psychosis because there's not a lot to talk about there except for on the teen side of it with some onset psychosis and some of the cultural stuff that's happening with teens, and like it's kind of cool to have DID now. Anyway, and we'll also talk about depression, pediatric bipolar and DMDD.
Thank you.
Yeah, thank you.
Wow.
And then Donna had a question. Is there a site you recommend to learn more and to stay plugged in? So like, yeah, well, I would say following Russell Barkley's stuff as it relates to ADHD would be a great place to stay connected with.
Last name is B-A-R-C.
Barkley.
Thank you.
Yep. In fact, how about this? For coming to class today, I'm going to reward you guys with, I'm going to give y'all a Barkley. Y'all want a Barkley book?
Yes.
Yeah. Let me,
That'd be awesome. Thank you.
Everybody's
with all
saying
with all the free time that you have.
it.
in
Well,
your
you
lifetime.
know, this is like you said, it's not understood.
Right.
This was a huge awareness that I might have a little cry when I get off of the session because it just is like, what in the world is happening that we've been missing this so much?
Yeah, it's unfortunate. If you'll give me 2 seconds, I'm going to give y'all access to download Barkley's newest, it's 2022 published ADHD authoritative guide for ADHD for parents. Yeah.
So is this the type of thing that I mean, it seems like if you're working with a child who is suffering from this, that, like you said, you got to have the parents in there, the caretaker, so that they can come to understand and assist. Do you recommend that they read these types of books to help them understand?
Mm-hmm.
Okay, great.
I do, and almost none of them do.
That's so sad.
I say almost none of them.
Well,
They don't immediately until and then they start remembering some of the stuff that I said, and after the fact, after things kind of get rough. And so I wish I could prevent it from getting rough, but I know that, hey, at least they know where to turn when it's time to turn.
you said it was called ADHD Authoritative Guide.
Yeah, I'm about to put it in the chat so y'all can just click on it and download it.
Thanks.
Let me get there.
Okay, while you're doing that, just a question, and I'm not sure how exactly to ask the question, but you mentioned earlier that we have this other side of this problem, which is the fact that it's so easy sometimes to get your kid diagnosed as ADHD. You check the boxes. So how does that fit into all this? I mean, if we've got these multitudes that don't even have it, I don't know what I'm trying to ask there. Like, how do you tackle that?
Sorry,
because I'm a teacher and I have like all these kids that are diagnosed as ADHD. And obviously I'm not going to sit and argue with somebody and say, well, they don't have it. Because
Sure.
like you said, that it shows up in different ways. But if we know that a lot of kids are getting diagnosed that really aren't, then what does that mean for us?
So I would say our job is really to help. Well, here's the thing. Any of the interventions that would work for ADHD, even if the kiddo doesn't have ADHD, good news is, guys, guess what? Executive function intervention is probably like 10 times more like long-term predictive of health and success than even like all the academic intervention in the world.
Okay.
Or all the, yep. And so, in other words, anything that you would recommend for kids with ADHD is also going to be helpful for kids without ADHD.
So we don't need to worry about that part. So it'll take care of itself. Okay.
And then also, having good resources that you trust, that know this stuff, who can help either with diagnostics or the treatment side. And I'll be honest with you, I don't have a lot of resources. I wish I did. I have a few, but I don't have a lot of that can do the treatment side very well.
That's unfortunate.
It is.
Maybe you could write a book.
There you go.
I'm in
Uh,
the process of writing it.
Good. That's awesome. And then they can make an
My
ampersand
process, I'm
course.
thinking, that means I'm thinking about it, I guess, really.
Yeah, but like you said, if you it depends on the content or the context,
Mhm.
right? Because if you really, then you'll damn that thing out in no time.
Mhm.
And then you
Well,
can create a course.
I am very passionate about it because there's just a lot of misinformation. And if we really could see the brain, I think there'd be a lot more empathy out there for these kiddos. You know, in the same way we have empathy for the kiddos on crutches or in a wheelchair. Like, I think there'd be a lot more empathy, which would help.
I agree.
All right, everybody get that?
Yep. I did get
Awesome.
it. Thank you so much. We'll see you
all
guys
right.
tomorrow.
Yeah. Well, y'all have a great rest of your day. And
Appreciate you.
Thank you.
we'll see you then. Take care.
Thank you.
Thank you.
Cool. Thanks.